cloud. Yeah.
Where's that? How do I get that up there?
I can get it from you later. When
Okay.
when I end the meeting, or you end the meeting, when you end the meeting,
Okay.
it should be in your documents.
Okay. Great. Well, let's get started then. It does seem to be recording. So hello, everyone out there online. My name's Haley Christian. I'm a staff cardiac intensivist here at Sick Kids Hospital. I've been here for a couple of years and did all my training in and around Canada, BC. So Cecilia has graciously invited me today to talk to you about heart failure in the critical care unit. It's a very general talk, actually, and really the goal was to provide a conceptual framework from which to approach heart failure. We'll talk within that framework about the etiology of heart failure that we see more often in this ICU or cardiac ICU setting. We'll talk about what that presentation looks like within each of those categories. We'll talk about some of the lab markers and monitoring data. It's not an exhaustive list that I'll be providing you. I'll be focusing more on what, for example, I would look to more often. Exhaustive lists can sometimes be exhausting. And then we'll talk about what is the appropriate medical, focusing primarily on medical management, but also when is it more helpful just to move forward towards surgery. And we have until 11:30 for this talk. I'll try to leave 15 minutes at the end for questions, but I am also happy to provide clarifying points. Cecilia can watch the chat, and otherwise, if it's something that you want answered before we move forward, I think as well you can hop on with your mics and interrupt me, and I'm fine with that, although it is recorded, so just be aware of that. All right, so the framework I want to think about on a higher level for heart failure is basically 3 categories. Sometimes when we think about heart failure, we think about, say, adults with coronary artery disease, or we think about, maybe you think about VSDs and work of breathing. But I think it's helpful actually to divide it into the 2 sides of the heart. So do you have right heart failure or do you have left heart failure? To divide it as well, or label it as systolic dysfunction or diastolic dysfunction. And lastly, to label it as either a low cardiac output or a high cardiac output situation, because the presentation and management will significantly vary between these categories. So we'll start just by generally describing each of these categories and scenarios, and then we'll move to some cases just to get the clinical juices flowing. So when I'm talking about right versus left heart failure, I'm literally talking about the right or left side, or with congenital heart disease, subsystemic or subpulmonary sides respectively, failing in some manner. So if you have a failing right heart, essentially what will end up happening is blood gets, in simple terms, backed up in the systemic venous return. You'll develop things like pleural effusions, tissue edema, ascites, hepatomegaly, liver dysfunction, and this all relates to these higher right atrial filling pressures because of RV dysfunction. Left-sided heart failure is a little bit more classic, I think, in what we think about with heart failure, is essentially the same process of backing up into higher LA pressures, but then resulting in pulmonary edema and lung problems. This obviously has a more significant impact as well on cardiac, or more direct impact on cardiac output. So you may see more of an inadequate perfusion or shock type picture. And how subtle that is depends on your degree of failure. Things like renal dysfunction, feeding intolerance, all the way to more extreme things like lactic acidosis and low mixed venous oxygenation. In terms of the broader category of systolic versus diastolic dysfunction, again, the more classic heart failure that we think about is systolic dysfunction. Things like cardiomyopathies, myocarditis, ischemia, sepsis, these things where the myocytes essentially aren't contracting as you'd expect. This results in a reduced stroke volume, and then that blood that's left over in the ventricle results in a higher end diastolic volume, and then, within the confines of the compliance of the heart, eventually a higher end diastolic pressure. And we would treat this with things like inotropy to improve that contractility. Diastolic dysfunction, on the other hand, is an impairment in the ability of the heart to relax, which is in fact an active cellular process. But that can be impaired. It can also be impaired by mechanical forces that reduce the compliance of that tissue, things like hypertrophy. And so the classic clinical scenarios we'd see were things like HOCM, and that stands for hypertrophic obstructive cardiomyopathy. You also get hypertrophy related to afterload. So congenital heart disease that has mechanical restrictions like an aortic stenosis, for example, or higher SVR, things like systemic arterial hypertension. What essentially this results in is a higher end diastolic pressure because the muscle is thick and can't relax, and then a lower end diastolic volume. So the ventricle can't fill with as much blood as it could before, which can result in a reduced stroke volume. You could maintain your stroke volume by just ejecting a greater proportion of that blood, but in more severe cases that we're seeing in the ICU, we often see impaired stroke volumes or evidence of impaired stroke volumes. And the treatment for that is really making sure that you have enough preload to help force blood in there, but you are going to cause higher pressures in that context by using that preload. So the last category to consider is output. Are you in a high output situation, and that's cardiac systemic output, or a low output situation? High output heart failure is this classic left to right shunt VSD scenario. So if we talk about things like QPQS, which we do a lot in the cardiac side here in the ICU, basically what that means is what is the ratio of blood going to the lungs versus the blood going to the body. And if you have a VSD, you can have a large degree of blood going from the left ventricle through the VSD into the right ventricle and back up into the lungs. And that's inefficient, right? It's RV, lungs, LV, RV, lungs, LV, and it doesn't get out to the body. So if you, for example, have a 2-to-1 QPQS or 3-to-1 QPQS, you have to be inputting, 300 or 400 times, or 400%, 3 to 4 times the amount of cardiac output. So the heart is working overtime. You also get these scenarios in any congenital heart lesion that allows blood to go from that left or oxygenated ventricle back into the lungs. So that inefficient blood flow. So things like TGAs and single Vs, truncus. And in these contexts, you usually have a normal tissue or organ perfusion because the because the heart is able to compensate and do this extra inefficient work of sending blood to the lungs. But you have a high pulmonary blood flow, and therefore the development of pulmonary edema. You also have lots of blood coming back from the lungs into the left atrium. And that increases your LA pressures, which also contributes to pulmonary edema. So 2 reasons that you get pulmonary edema in high output failure. And the treatment for this is get rid of some of that extra fluid on the lungs, diuresis, reduce the pulmonary blood flow. We'll talk a little bit more about that. Or you could just do surgery. And so when children are in significant degrees of high output failure, that's where we start to see indications for surgery. Low output failure, on the other hand, is just like low Q, and Q represents just cardiac output. So regardless of how much pulmonary or systemic flow you're getting from a ratio standpoint, it's inadequate to provide oxygenated blood flow to the tissues. And so you get inadequate tissue and organ perfusion. You see sequelae of that, like renal dysfunction. You might see frank shock. You also get often pulmonary edema, but that's due in this case more to higher LA pressures from inadequate ejection of blood from the left ventricle. And the treatment here does relate obviously to the etiology, but we're thinking about things like inotropy to let the heart contract more, afterload reduction so that it's an easier way out, and diuresis. Having a lower blood volume still does help to treat the pulmonary edema in the lungs from the high LA pressure, but it's obviously confined to how much preload or fluid you need in the body to maintain that cardiac output. So it's always a balance here in the ICU. We're going to jump right into cardiopulmonary interactions. I mean, to simplify this table, what I really want you to take away from this session is just one or two simple concepts. Positive pressure ventilation, whether that be CPAP or intubation, will help the left side of your heart, and it will hurt the right side of your heart. And an easy way to remember that is just to think, if you're putting pressure into the lungs, it's the right-sided ventricle's job to get blood up into the lungs, and so it's harder. And if that's the easiest way to remember it, that's fine. That's why we try to get positive pressure ventilation off of patients who are in right heart failure or have right ventricular dysfunction. On the understanding of why it helps the left side of the heart, you can get really detailed into physiology, but if it helps to just think about it a bit more concretely or generally, essentially the positive pressure in the chest is helping to push blood out. It comes down actually to transmural pressures on the ventricle, and when we're breathing spontaneously, we're creating negative pressure, right? You're breathing in, creating negative pressure to get air to flow in. Well, the heart has to pump against, the left side of the heart has to pump against that negative pressure when you're breathing in, and that's extra work for it. And that's related to that transmural pressure. But all that aside, just remember that positive pressure ventilation hurts the right ventricle, helps the left ventricle. Just let that sink in and see if there's any questions about that. The dog has a question, but.
Haley,
Hi.
you see under participants, if you toggle under participants, if you can just silence VGs, because now that I made you, now that I made you host, I can't.
Now I'm in control.
I should have made you co-host.
Yeah, I got it. Okay.
There you go.
So this slide relates, it is a little bit more of an extra nuance to these cardiopulmonary interactions. And so it can be of interest, or we can talk about it more later afterwards, or you can Google it. But essentially, what I just said in this table is true, as long as you don't have a whole bunch of atelectasis, collapsed lung. If you have atelectasis, you actually increase your pulmonary vascular resistance. And you can, again, just, I like to think a little bit concretely sometimes, like just think of all these lungs squished and the blood vessels, perialveolar blood vessels around them, like squished as well. You can kind of see this diagram here. That actually increases your PVR, so it makes it harder for the right ventricle to pump. So if you improve that with positive pressure ventilation, you're actually helping the right ventricle in that context. So an extra little nuance. All right. So let's just jump into some cases. I'll sort of briefly go over them, but you're welcome to just read and ignore me as well. And then we will have fun trying to do some polling. And it's meant to just sort of get us in the habit of simply categorizing these types of heart failure. And I'll go a little bit into the management of each one. So here we have a 6-year-old. He has a new diagnosis of dilated cardiomyopathy and was admitted from the ER with echo findings showing a dilated left ventricle with an ejection fraction of 28%, normal being sort of more in the 50 to 60% range. The RV is also a little bit dilated, but just mild dysfunction, seems to be doing a bit better. The urine output's been calculated while he was in the ER as lowish. His weight is 24 kilos, but was measured at a pediatrician's office a couple of weeks ago at 20 kilos, so up 4 kilos. We often call that sort of the dry weight of 20, or guess that that's a dry weight before he started to get sicker. His heart rate's 150, his rest rate's 35, so a bit tachycardic and tachypnic. Blood pressure seems to be okay. Needing a bit of oxygen with some lower sats, has some mild work of breathing. He's kind of irritable, pretty pale, cool to the peripheries when you examine, cap refills, prolonged essentially, and has weak pulses in all 4 limbs, weaker than you'd expect. His abdomen's soft, his liver's about 2 centimeters below the costal margin, doesn't strike you as too abnormal. And when you listen, he's got equal errantry, but crackles bilaterally. Some of the important blood work that's highlighted is creatinine of 110, so presumably elevated, but you don't have a baseline. BUN's 8, sodium's 130, but on the low side, potassium's 4.8, lactate's 3, so abnormal, and then has a bit of a, sorry, I have to minimize this. So it has a metabolic acidosis on the gas. Liver enzymes are normal, and the mixed venous is 52. When we think about mixed venous, we always think about the AVO2 difference, right? How much oxygen is being extracted from the arterial side. And it looked like his SAT probe was showing around 92. So an AVO2 of 40 is wide. So his body's extracting a lot of oxygen. So let's try this pull thing. So what I'd like you to do is identify which of these types of heart failure or myocardial dysfunction apply. And you can click multiple choices. What label can you put on this kind of patient? Cecilia, is it available to the participants
now? So if you scroll, like put your cursor right up at the roof of your computer, then the screen should come down for the poll. So then if you click on poll, then you should be able to launch it.
Oh, relaunch, there we go. Okay, continue. All right. Can you see it, Cecilia?
Yeah, I can see it. So everyone can just click on whichever choice they feel and then press submit.
This is fun. Some of these innovations from online learning, kind of more fun than real life class.
It's true.
Okay, awesome. So we have about half of people have voted. I'll give you some more time, read through and have a think. Try to get to about 75%. So if kind of 4 or 5 more people can take a guess.
And you can answer more than one choice in this, right, Haley?
Yeah. Obviously, clicking both low and high output would probably be wrong, but yes, so there's just those 3 categories there, right? Yeah. So maximum 3 choices, basically. Okay, great. Well, let's work with that. So this is primarily systolic dysfunction. And the evidence that we got a good amount of people choosing systolic. And the evidence of that is the reduced, so first of all, with dilated cardiomyopathy, it's often dilated because of inadequate contractility, which can be secondary to things like a burned out myocarditis, or a genetic cardiomyopathy or deficiency in the contractility of the myocytes. And eventually over time, the ventricle becomes volume and pressure overloaded and just starts to dilate. But it comes from a primary systolic dysfunction. You have a reduced ejection fraction, so your ventricle's not squeezing as much. You have some pulmonary edema as well, and you have evidence of sort of shockiness or low output. So I see as well that many individuals have picked low output and nobody picked high output. So that's right. You did have a picture of a patient who has inadequate tissue perfusion. And the question of left or right-sided really was trying to get at, is it the lungs or the systemic venous return that seems to be the predominant feature? So definitely there's evidence of left-sided heart failure. You have this pulmonary edema, you have work of breathing. It's probably from higher LA pressures in the ventricle. Right-sided, well, you would expect that potentially the higher LA pressures get cause further backup and cause a higher afterload for that RV to pump against. And so you can get right-sided evidence of right-sided heart failure in these patients, and you have some mild dysfunction there. So this was more of a question of degrees, really. So there is some evidence of mild right-sided dysfunction, but you don't have a really big liver, your liver enzymes are normal, there's no significant effusions or evidence of effusions. So it seems to be predominantly a left-sided systolic dysfunction with low output. Okay, end poll. Great, share results. Oh, I should have done that earlier, sorry. There's what you guys answered. So, and then I'll just close this. So again, just to walk through the pathophysiology of a dilated cardiomyopathy, you have left-sided systolic dysfunction with low cardiac output. You have a low stroke volume, low cardiac output. You have high left ventricular end diastolic volume because you're not ejecting very much. The amount of volume that's left in there is reasonably high after systole. And so with your diastolic as well, you end up with higher pressures. That affects your left atrium, those high LA pressures, and then that affects pulmonary edema. You would manage a situation like this with inotropy. So epinephrine's a sort of standard choice for that, with those, that beta activity, right, for the inotropy. You want to make the job easier for the left ventricle, so you use something like milrinone is an often used. If you're actually hypertensive, sometimes we use a faster acting agent like nitroprusside. Positive pressure ventilation can help out the left ventricle, and it's under the category of afterload reduction because of this transmural pressure and kind of helping to squeeze out the blood. That's sort of the classic answer for how positive pressure helps out the left ventricle. You may very well need to address fluid overload. So this patient was 4 kilos, just 4 liters above dry weight. So you give Lasix, and that helps the pulmonary edema, and you fluid restrict. And a patient like this who's had chronic heart failure is often very thirsty and not wanting to fluid restrict because the body recognizes it's starved for blood and it's trying to that's its priority. It's trying to increase the preload as much as possible to get blood volume to send oxygen to the tissues, but it's a short-term solution. Over the longer term, this causes more problems. So you have to fluid restrict and provide Lasix. These patients often do have failure to thrive because they either they have feeding intolerance or just the inadequate tissue perfusion. So optimizing calories is quite important, and often you have to balance that with fluid restriction, especially in infants. And then if they're really shocky, reducing metabolic demand. So how do you reduce metabolic demand? Things like sedation, things like helping out the breathing, and watching the temperature. Now, this patient's, any patient with significant left ventricular systolic dysfunction is going to be a very high risk of intubation. When you intubate, you give sedation, reduce the SVR, that can drop the blood pressure, drop the coronary perfusion, and in a heart that's already on the edge, significantly impact contractility. And you're also changing the loading conditions. So even though positive pressure helps out the left ventricle, during the process of intubation, if there's high degree of positive pressure, the impact on the right ventricle and on the preload can have a significant effect, enough to reduce preload in the left ventricle and cause something like a cardiac arrest. So very high risk intubation for these severe systolic dysfunction situations. Okay, just leave it there in case there's any questions. That's the simple answer to how to treat dilated cardiomyopathy. I didn't go into things like VAD transplant. These are kind of next steps. We're just talking about what we're doing right now in the ICU. Okay. So another case. Now we've got a 5-year-old who's 22 kilos, pretty healthy on history, has some viral illnesses in the family, not COVID, brought into the emergency room by parents, was breathing quite fast for over 24 hours, had a mild fever. He's fussy, irritable, not eating well, but it's really an acute onset. He is very tachycardic, 180. Blood pressure is okay, a little on the soft side. He's, that should probably say like 30 or 40. He's very tachypnic, a little bit of a temp, weak pulses, delayed cap refill, sliding okay on no oxygen, but definitely working a little bit to breathe, and has crackles bilaterally. And the liver edge is now felt about 5 centimeters below the costal margin, and it's like hard, you can feel it. Has a bit of a white count, 20, glucose is 8, and then you have a chest x-ray, just envision it, hazy bilaterally with small pleural effusions. And then you're also seeing frequent PVCs on the telemetry. So let's think about what this might be and think about how we can categorize this heart failure. So polling, stop sharing, relaunch poll, continue. So it's always going to be the same question. And you can, to try to be clear, you can have right and left at the same time. I said max 3, but I guess it's max 4. Yeah, really, you could have systolic and diastolic at the same time too. So max 5. You just can't have low and high output at the same time. Okay. Great. So we've got about half the answers. Feel free to keep clicking them in. I'll just start talking. So is this systolic or diastolic dysfunction? Well, I think the primary problem is likely systolic. And that's because of the sort of shockier picture. It's pretty extreme tachycardia for a 5-year-old is suggestive that your stroke volume is quite low and you're trying to compensate with that heart rate. And in fact, I should have been specific to say that it was narrow complex so that you weren't thinking about arrhythmia, but seemed to be a sinus tachycardia. You could have a degree, certainly, of diastolic dysfunction in a myocarditis because both actions of the myocytes can be impaired, but we more often see evidence of inadequate sort of forward flow or perfusion. We don't see as much a predominant component of diastolic dysfunction. And that's important just because the treatment for these two types of heart failure are different, right? We need to give adequate preload, but we don't want to fluid overload this patient with primarily systolic dysfunction. Is it low or high output? Well, I think it's low output, and I think it's low output because the pulses are weak, the cap refill is delayed, the patient is so, well, I guess you could be tachycardic with a high output for sure, actually, but so I guess it's focused more on the perfusion. The left or right-sided predominance, I think you have both here. So you do have crackles bilaterally and moderate work of breathing, which is telling you that you're in this clinical context that you probably have high LA pressures related to inadequate ejection and stroke volume because of systolic dysfunction. But you're right, you also have right-sided, share results, I'll get better at this. You also have right-sided dysfunction as evidenced by some pleural effusions and a liver edge that's lower. So this was a case of myocarditis. In myocarditis, as mentioned, impacted left systolic dysfunction. You can also have right systolic dysfunction, but the clinical sequelae that you see are more often related to shocky type pictures with pulmonary edema. You also, in myocarditis, have myocardial hyperexcitability. So this was these PVCs that you were seeing, and the more frequent you see them, the higher the risk that the patient could go into VT. And in fact, sometimes you get these little runs of VT. In terms of management, we treat the systolic dysfunction with an inotrope, epinephrine. We also want to try and keep the pH relatively normal to help out that ventricle. We make it easier to do its job, things like milrinone or something shorter acting if you're worried about blood pressure being too low. Positive pressure ventilation, again, a high risk intubation for the same reasons discussed in the last case. Fluid overload, same management as the last case, restricted by your blood pressure. And failure to thrive or shocky picture can be addressed by reducing your metabolic demand. In terms of the myocyte hyperexcitability, keeping your pH normal also helps. Your temperature normal helps, but we pay specific attention to the electrolytes in this case. So we'll be looking at wanting to keep potassium over 4 and magnesium over 1. Calcium is also something to watch. That higher calcium will help out your inotropy, so usually somewhere over 1.1 or so. But really it's the potassium and the magnesium that we'll be hyper-focused on with respect to arrhythmias. And obviously if you're increasing your epinephrine, you may very well be putting your patient at higher risk of VT. So you have to balance these two issues in these patients with myocarditis, and they can really walk quite a line. All right, I've got time for some more cases, so we'll keep going. I'll relaunch the poll now, and you can answer whenever you like. So now we have a 2-week-old who had obstructed TAPVD. Cecilia, have we covered TAPVD in the course yet?
Yes, we have.
Great. So first day post full repair is still intubated, but seemed to be doing relatively well. Post-op TE showed good biventricular function. So that was right after the OR in the operating room. Had a systemic RV pressure, flat septum. They did not leave an ASD. This isn't super true to life because we usually do so that we can access veins, but we didn't leave one in this case. Is more tachycardic this morning on assessment as you're coming on for your shift. So 185 for the heart rate. Tachypnic is on a sort of pressure support mode working towards extubation, but breathing quite a high rate above that. Blood pressure's okay. Oxygen's diffusion's not bad, so SATs of 90 with an FiO2 of 40%. Baby's irritable. On exam seems well perfused. Liver edge is low. Oops, sorry, I gave the answer. Liver edge is low, and abdomen's quite full. So you also have some evidence of inadequate tissue perfusion. So your lactate's up, your pH is 7.2, which it seems to be more of a respiratory component. Creatinine's okay, and your mixed venous is 67, which puts you at a gap of about 23, right? So not so bad. And that might be something that's variable. So there's some mixed results there. So this is interesting. This is good. Okay, so we need some more votes. We've got 3 votes. Let's have a think. Is this so I haven't given you the echo results. I've just shown you a patient who looks like they might be getting a little shocky, the lactate's going up. And that mixed venous actually in real life would probably be a bit lower if your lactate's going up. So let's say those are true values. And seems to have a liver edge that's going down. Otherwise seems to have like reasonable pulses, but you're a little bit concerned about the perfusion because of the lactate. And you know that this is a post-op TAPVD who had RV pressures and good systolic function after the OR, or sorry, systemic RV pressures. It's a little bit of a trickier one. I'll wait a little longer for some more answers, and then we can just talk through what kind of failure we might be seeing here. All right. Last couple more seconds if you want to do some quick guesses. Okay, I'll share these results now. Just so we can get through the cases. So this was a case of pulmonary hypertension. So these TAPVDs, especially if they were obstructed to some degree pre-repair, because they've had those high PA pressures, they are at risk of a reactive pulmonary vascular bed or some degree of sort of consistent pulmonary hypertension. And so this patient had systemic RV pressures, so that's indicative of pulmonary hypertension post-op. And that was when the patient was like sedated in the OR, totally relaxed. And now as you're starting to see, because the compliance of the lungs was reasonable, as you're starting to see whether you can move towards extubation, all of a sudden the patient's showing some signs of inadequate tissue perfusion, more tachypnic, so signs of like poor lung compliance because she's having to make up the small lung volumes with more breaths, and signs of right-sided heart failure, so the liver edge is down. So in this case, it's likely systolic dysfunction that you're dealing with, and it's in pulmonary hypertension. That's because all of a sudden the RV has to start dealing with a higher afterload, and that pressure load causes myocardial dysfunction, or just can't be superseded by a baseline degree of contractility that this patient has, especially a neonate post cardiopulmonary bypass. Now, the diastolic dysfunction. So certainly a patient who's been subjected to high pulmonary pressures could have a degree of hypertrophy and diastolic dysfunction. And neonates by virtue of being neonates and then having bypass, have a degree of diastolic dysfunction. So that's not wrong. I think the primary component with a sudden pulmonary hypertensive episode so a high RV afterload would be the systolic component. And I say that because then the management of the situation is to give epinephrine, to give inotropy. But you're right that you also will need potentially a degree of preload. The other thing that's really important in pulmonary hypertension is to reduce the afterload of the lungs. Now we're not talking about reducing, using milrinone to reduce systemic afterload. We're talking about the lungs. And in a patient like this, we would have a very low threshold to start something like nitric oxide, crank up the FiO2 to over 60%. Even if the SATs are okay, that extra FiO2 will give some degree of pulmonary vasodilation. Not as much as the nitric kind of takes over. Make sure you're shooting for a more normal pH temperature, so avoiding hypothermia, and making sure the patient's sedated, comfortable, so that their endogenous catechols aren't being released and increasing your pulmonary vascular resistance. And the other thing that's a little bit, maybe not harder to understand, but like a little bit more indirect, is systemic vasoconstriction. So how could systemic vasoconstriction help in this case? Well, number one, when you give systemic vasoconstriction, you're giving a preload because you're squeezing the arterial side. You're also squeezing to some extent the venous side and helping to push blood into that space. The other interesting thing that it does, let me just see if I have the next slide here, is in pulmonary hypertension, because you have this high afterload on the in the PAs on the RV, the pressure actually pushes that septum over into the left ventricle. And when you do that, you can see you reduce the cavity size of the left ventricle, you reduce the preload in the left ventricle, and that in and of itself can reduce the stroke volume and the total cardiac output. So if you provide an increase in your systemic vascular resistance, it's like you're pushing back that septum back over, and that's helping the preload of the left ventricle. So sort of indirect functions. But the main features I wanted you to take out of this case were the fact that you were having systolic RV dysfunction in the face of an afterload, and you were helping it out by increasing the contractility of the right ventricle and reducing the afterload. Okay, so we're at the 15-minute mark before we're done. I have some concluding thoughts, but if we don't have too many questions right now, I'll go over at least one more case. So I'll just pause here and see if anything I just said there requires some clarification for the group.
Yeah, can you just overview that was systolic dysfunction primarily, and just the rest, it was, sorry, I can't even think of the words.
That's okay.
Predominantly right-sided then?
Yeah, so it's,
okay.
Sometimes it's hard to say things, it's one exclusive phenomenon in the ICU, right? So many of our systems are interrelated. And if you have poor LV function, then, things can back up and cause problems on the right side. So it's hard to say that things are only one thing. And that's why I like the idea of this poll, because it wasn't really to get the right answer. It was just to think through what evidence we have of each. In the face of pulmonary hypertension, the primary pathophysiology is that if you have a sudden pulmonary hypertensive crisis, your RV will start to fail in its systolic function because of the high afterload. So systolic RV dysfunction with a lower output state because of the fact that you're not moving blood all the way through the circuit would be the predominant features of this case. Could you have evidence or other issues coming in? Yes, but those would be the predominant three. Okay, thanks for clarifying. I started to get a bit more creative with the cases as they move forward, so they get a bit more complex. So I'd like to do, let's do this one, the repaired TET. Relaunch poll. There we go. Okay, so this is a 4-month-old TET, basic TET PS, post-up day 1, valve sparing repair, had a VSD patch, good biventricular function on the TE. They closed the ASD as well. Patient's intubated, came back to the OR, stayed intubated overnight, maybe came back late. Is tachycardic, a little bit tachypnic, not too bad. Good blood pressure, good SATs, seems well perfused, good pulses, decreased air entry to the bases, full abdomen, and the liver edges down 4 centimeters. Has notable tissue edema. And on X-ray, has pretty clear lung fields, but moderate pleural effusions bilaterally. Has a normal gas. Creatinine's like a little elevated, but not too bad. But the liver enzymes in the billy are more markedly elevated for you as you look at your morning labs as they come back. So what kind of heart failure do we think we're seeing here? Systolic or diastolic? Predominantly. Systolic or diastolic, lower high output, left-sided or right-sided? I suppose I should have put normal output there too. I still have lots of results coming in. More seconds. Okay, I'll end it there and we'll talk. So this was meant to be a pretty classic post-op TET who has diastolic dysfunction, reasonable output, probably shouldn't have made you answer low or high, reasonable output, and predominantly right-sided. You could say right-sided heart failure, or a more common vernacular in this case would be to say right-sided dysfunction. So I'll just go to the next slide here. So this is our tetralogy of Fallot, and in tetralogy of Fallot, you have a right ventricle that is facing for a period of time pre-repair a higher afterload. It's facing an afterload of usually subvalvular dynamic pulmonary outflow tract obstruction, but it also is facing usually an unrestricted VSD that actually means that the RV is pumping against systemic pressure. But it's really this, this obstruction to flow into the lungs that causes a secondary right ventricular hypertrophy. Usually systolic function is maintained, but you have diastolic dysfunction because of the hypertrophic muscle. So we would call this diastolic RV dysfunction, probably a normal output. And the diastolic dysfunction means, again, you have a high end diastolic pressure because the blood that flows in there is in a stiff or non-compliant ventricle. You can maintain your stroke volume if you eject most of the blood, even if you have a low end diastolic volume. But usually the stroke volume is impaired. And in this case, it probably is, as evidenced by the tachycardia, right? That's trying to compensate. You end up with higher RA pressures and then systemic venous congestion. So this patient had the liver enzymes, the ascites, the pleural effusions. If the stroke volume is so inadequate that you have a decreased return to your left atrium, you can actually have a decrease in your systemic output as well. Sometimes we leave the atrial septum open so that we can have blood flowing right to left to help maintain that LV preload. And the decision to leave that would be because you're in the OR, you're concerned that the RV diastolic dysfunction is going to be so bad. So on a handover, if you get, oh yeah, we left an ASD, and on the TEE, it's shunting bidirectionally or right to left, that shows you that there's evidence of higher RA pressures and of RV hypertrophy. So the management in this context, well, in really bad cases, I suppose you could go back in and put an ASD in there, but we're only post-op day 1. We can do some medical management here, and we don't often have to do that. So what you want to do then is provide adequate preload to that RV. Like you need to have enough pressure from enough preload to get as optimal an optimal stroke volume as you can. And you want to reduce the RV afterload because your stroke volume, even though your systolic function should be fine in these cases usually, any sort of help that you can give to the right ventricle to eject as much blood as possible will improve the scenario. If you have systolic dysfunction as well, that can be a big problem. This next case, I won't go through the polling questions. I'll just walk through it with you. It's a similar context or concept, but now we're dealing with biventricular hypertrophy. So this is a patient with HOCM. And Noonan's would be associated with HOCM, 4-month-old baby who's admitted in the context of a cold. So when you have biventricular hypertrophy, you can cope for a period of time, but if your metabolic demand increases with an infection, for example, then because your stroke volume is so limited, you really can start to decompensate. And if you are ending up with higher filling pressures because of a higher cardiac output going through this heart that's so stiff, you'll end up with pulmonary edema and systemic venous congestion, so both sides. So this patient came in very tachycardic, tachypnic, blood pressure's kind of on the edge. And these patients with HOCM and Noonan's, when they're this young and they have it, they often live very precariously from a hemodynamic standpoint. There's evidence of inadequate perfusion, so left-sided issues and right-sided issues with the hepatomegaly. And this patient is, if the TET was preload dependent, this patient, because they're biventricular hypertrophy, are very preload dependent. And you have to find the sweet spot, because once you reach an optimal level of preload, the more you give, just the more pulmonary edema you're going to get, right? And so if we're trying to diurese these patients, often what you'll see is like, you'll be watching their CVP and like it's 12 and you're diuresing, and then it's 11 and you're diuresing, and then it's 10. And all of a sudden your blood pressure will, and your pulse pressure will just start to sag, and it'll do it a lot quicker than the average patient because this heart is so stiff. You just don't have any leeway. So you need adequate preload for your blood pressure, and you'll find at the bedside that you can find that sweet spot. The other thing specific to HOCM is that you use beta blockers to slow the heart rate at times, because if it's too fast, you're not giving time to fill. But if it's too slow, you're not giving enough cardiac output. So again, you find that sweet spot. And then this vasoconstrictor issue is really, again, related to trying to provide the preload. There is another reason to increase your SVR in HOCM. It's apart from this lecture. It's not related to other concepts in this lecture, but it has to do with kind of stenting open that left ventricular hypertrophy. So you can see if you can kind of stent open the left ventricle, perhaps you can get better flow through there. That's a side concept, I think, for another day. So if we just now in the last few minutes review some of our concepts to solidify them. We'll skip this VSD case. That would be a case of high output failure. It's showing signs of left-sided issues like pulmonary edema. And we'll just we'll just go to reviewing our objectives here and sort of solidify what we learned with these cases. You can find lots of cases of heart failure in the ICU. So remember, when you have a patient coming in front of you, you want to try and figure out what is the predominant feature here. So if there's systolic dysfunction, we're often seeing it in the context of dilated cardiomyopathies, myocarditis, or secondary to some other problem. If there's diastolic dysfunction, it's often a patient who had some afterload that they were fighting against or has a genetic disorder that is a hypertrophic cardiomyopathy. High output failure patients are ones with high pulmonary blood flow, but adequate systemic flow. So like the left to right shunts, or those patients like single ventricles where blood can go both ways, they can be in high output failure if their blood pressure is okay and everything, perfusion's okay, but they just have too much blood going to the lungs, high QPQS. What about the clinical presentation and labs that you'll be faced against? What kind of categories are you thinking about? Well, you're thinking about is this patient in low cardiac output, shocky? Is this patient fluid overloaded? Can I apply that label? They could be both. And what evidence do we see of those things? So we didn't talk as much about the fluid overload, but in terms of vitals, think about what are they up from their dry weight? How tachypnic are they in terms of their lung water? For labs, look at their creatinine and their BUN. If they're actually very, very low or going down, you might actually be more fluid overloaded. Sodium that's low is related to fluid overload. The clinical presentation of LV failure, think about lung blood backing up in the lungs and evidence of lung issues. RV failure, think about blood backing up in the systemic venous system, so hepatomegaly, pleural effusions. So pleural effusions, again, are different from pulmonary edema in that it's sort of an outside space coming from the veins. High output failure, think about your classic VSD patient who's got primarily lung issues from high pulmonary blood flow, but their systemic output is usually pretty reasonable. What is the appropriate management? Remember, if you've labeled your patient as having systolic dysfunction and decreased contractility, they, depending on the degree, they may very well be inotrope dependent, and you want to make their LV, you want to reduce the afterload of whatever ventricle is having problems. So either reducing your SVR or reducing your PVR. If you've labeled your patient with diastolic dysfunction, you think about having adequate preload, usually fluid, or maybe you're using a norepinephrine or increasing your SVR to help with that preload. If you've labeled your patient with high output failure, you're going to be dealing with pulmonary edema. So diuresing, fluid restricting, and trying not to over supply the lungs with blood. So watching that you're not giving too much FiO2, for example. And again, you can fix it with surgery. For fluid overload, we're talking about diuresis and fluid restriction. For shock, we're talking about supporting cardiac output and minimizing what the body needs. And how much you do depends on how severe the shock is. So thank you. I hope that this way of categorizing things and applying labels is helpful as you're moving forward, trying to think about identifying and managing the types of heart failure that you see in the ICU. So that is 1 minute over time. So we should probably stop there, but Cecilia has my contact information and I'm happy to receive any questions moving forward.
Thank you, Haley. That was a really nice way to illustrate the different kinds of heart failure.
Okay.
So could you also just stop the recording for me?
Yes.
You're still host.
Still the boss. Okay,
Yeah.
stop recording.
Yeah.
Stop.